Hello, everyone. Thank you for joining today's session on your favorite channel, Cancer Reach. Cancer Reach is an initiative by our very own oncologist, Dr. Krishnamani, to spread awareness about cancer and to help patients and caregivers to access the right treatment at the right time. Welcome to today's YouTube live session on Rarest of the Rare, Paragangliomas and Pheochromocytomas. These are uncommon tumors that arise from nerve cells involved in our body's stress response. Though rare, they can cause significant symptoms due to excess hormone release and often go undiagnosed for years. Today, we will try and understand what these tumors are, why early detection matters, and what treatment options are available for them. So, without much further ado, let me introduce our doctor. He is Dr. Krishnamani, one of the most respected voices in oncology. He has been with AY hospitals here in Hyderabad for over a decade, where he is known for his expertise in managing solid tumors, blood cancers, and oncological emergencies. His journey spans international fellowships and leadership roles at some of India's top cancer centers, giving him a truly global perspective on cancer care. He's also contributed immensely to the field, from shaping treatment protocols to influencing cancer care policies and driving research that makes a difference. Welcome to you, sir.
Hello, welcome to Cancer Reach. Cancer Reach is a platform where we want to reach patients or caregivers regarding cancer awareness. And today, as you say, we are going to talk on a very rare and not often discussed topic, which is called pheochromocytomas, or also another name for these kind of tumor is a paraganglionoma.
Sir, can you tell us exactly what these tumors are?
So what happens is there are certain primitive neural crest cells we say in the body. Okay, so they are there all through the sympathetic and parasympathetic chain. So we have a nervous system which is divided into a sympathetic and a parasympathetic nervous system. The neural cells there can form tumors, and if they form tumors, that is called a paraganglioma. Okay, and on the kidney, on both our kidneys, we have a triangular shaped organ called an adrenal gland. In an adrenal gland, if you get a tumor which is derived from the neural crest, that is called a pheochromocytoma. So these are tumors. They are mostly benign, but 30-40% are malignant also. That is, malignant means they have a chance to spread to other organs. They are neural crest derived in sympathetic or parasympathetic locations, adrenal, which is the kidney, just above the kidney, or non-adrenal locations.
Sir, when we say that they are rare tumors, what exactly are like the numbers that we're talking about? How rare are they?
How rare, if you ask me, suppose I see somebody with the, so what are your commonest cancers? Your commonest cancers are lung, breast, cervix, head and neck, colon, stomach, gallbladder, leukemia, lymphoma, sarcomas. This will not be in that list at all. It is that rare. Okay. So I don't remember exactly the incidence per million or per 10,000, but they are extremely rare tumors.
Okay. Sir, how do these tumors form in the body? Or what
See,
are its risk factors for the formation of these tumors?
one is sporadic, you don't know the reason. Two is familial. Certain people have certain inherited genetic predisposition syndromes, we say, like VHL, von Hippel-Lindau syndrome. If you have that syndrome, you can develop pheochromocytomas, paragangliomas, middle ear, CNS tumors, etc. Kidney cancers. SDH tumor, succinate dehydrogenase, that's an enzyme. If they are deficient in that enzyme, so you have a genetic defect. You are not forming a protein. The protein is not forming an enzyme. So you don't have that enzyme or that protein, you develop kidney tumors, pheochromocytomas, etc. So VHL gene, SDH gene, paraganglionoma gene 1, 2, 3, 4, we say. So there are multiple genes which have been suspected. So these are all responsible for the familial clustering of cases. So you may see some patients some people in a family affected in different generations. So those people have these genetic defects. If they don't have these genetic defects, you can do the blood test and find out. If they don't have it, then you are talking about a sporadic disease.
Sir, what are the common symptoms associated with these tumors?
So what we should understand is, see, these tumors form a lump. So lump is or a swelling is a common symptom. They can be secretory or non-secretory. Sometimes they release certain chemicals in the blood. That chemicals can increase your heart rate, increase your blood pressure, leading to sweating, palpitations, dizziness, fits. So symptoms are either due to the local tumor, which is swelling, pain, compression on nearby structures, etc. You can have a paraganglioma in the neck. You can have it here in the base of the skull. You can have severe headache, ringing sensation, tinnitus, we say in the ear. Okay, so these are all due to local pain, facial pain, neck pain, shoulder pain, ear pain, tinnitus or ringing sensation, etc., or a lump. Systemic symptoms generally for all cancers: weight loss, loss of appetite, fever, etc., vomitings. Secretory Pheos or paraganglionoma, secretory means they secrete certain catecholamines, some chemicals. That chemicals increases your heart rate. So you can have palpitation, you can have chest pain. Because your heart is functioning so fast, blood circulation comes down. So you get less blood circulation to the brain. You may feel giddy. You may have seizures. You may have a lot of sweating because your blood pressure shoots the roof. So high BP, high pulse rate, seizures, giddiness, syncope, sweating, all these are the other symptoms. So secretory related symptoms, local symptoms, yeah, and systemic symptoms in the form of fever, weight loss, loss of appetite, etc.
Sir, when you talk about the symptoms, would there be any specific warning symptoms for these tumors?
So
Any one thing that stands out?
yeah, the sweating, high pulse rate, somebody having 180, 200 pulse rate or 150 pulse rate, and you have excluded other causes. See, high pulse can be seen in fever, can be seen in anemia, if you are tensed, if you are on certain drugs. If you exclude all those reasons, then you should start considering this as an alternate diagnosis. Start working up that patient. High blood pressure not responding to therapy. See, somebody has a blood pressure of 240, 120. You don't see that commonly. You see 180, you see 160, 100, 240 or above 200s. There are certain causes which can cause this kind of a high blood pressure, like renal kidney problems or renal artery stenosis, we say. This is an important cause, pheochromocytoma or paraganglionoma. So these kind of unusual high blood pressures, high pulse rates, sweating, not fitting in a particular diagnosis, start thinking of. Many a times you incidentally pick these up. You do a scan for some reason, you pick it up. See, people may be having a small adrenal tumor, you never know. You do a scan for some reason. Okay, you may have a urinary tract infection, or you may have an abscess, or you just go to a master health checkup, you get an ultrasound. Then you are prompted to do a CT scan. So you can either be incidentally picked up or the symptoms can be these. These are the warning symptoms.
Sir, can we talk a little bit on the diagnosis? Like, how do you diagnose these tumors?
So when you have a patient who comes with this constellation of symptoms, you should have a very clear suspicion. Then CT scan or MRIs are your first step. You will do a you to see, do you have a tumor? Where is the location? For the head and neck, you do a CT or an MRI. Sometimes we also take the help of a PET CT or a dotatate PET CT, we say. That is number one. So basically, you're going to do imaging to see the location, size of the tumor, its relation to neighboring structures like vessels and nerves and veins and arteries, etc. Next, to differentiate between secretory and non-secretory, you have to do these blood tests for catecholamines, we say, metanephrines, we say. So it's a blood test where you measure certain chemicals called metanephrines. In the urine also, you measure the metanephrines. If they are elevated, that means that tumor is secreting. Remember, only 50% tumors are secretory. So if the metanephrines are normal, doesn't mean you don't have a pheo or a paraganglionoma. It's a non-secretory. It is not producing those chemicals. Doesn't produce chemicals, you will not have those symptoms. So you will do this blood test and urine test for metanephrines. You will do imaging to locate the size of the tumor, location of the tumor, spread of the tumor to other organs, and relation to nearby structures.
If a person in the family is diagnosed with this tumor, do the offsprings also get some screening
Correct.
tests done?
So you have to first test this gentleman or this lady, test them for those genetic mutations, test the offspring also. And if they are positive, then keep them under regular follow-up with ultrasounds or imaging or these blood tests to see that if you're able to pick up a disease at a very, very early stage.
So, sir, how do you categorize these patients and how do you plan the treatment for them?
So, are you an adrenal tumor or a non-adrenal tumor? That is pheo and paraganglionoma. Paraganglionoma sympathetic, non-sympathetic. Another way to classify is at the neck base of skull. We call it jugulotympanic, this area, neck area, head and neck area, or the other area. Okay, that is the way you classify secretory, non-secretory, non-metastatic, metastatic. So this itself will give you an answer. Is it a pheochromocytoma? That is it from adrenal? Yes. No means it's a paraganglionoma. Sympathetic, parasympathetic. Is it secreting any chemicals? Are you having all those symptoms? Yes, no. Has it spread to other organs? Yes, no. Metastatic, no. This is the way you classify.
Sir, is surgery a treatment option for these patients?
So when you come to treatment, the first thing please understand, before you do any treatment, you have to do a proper blockade, which we call. That is, you have to prime the patient. The blood pressures will be high, I told you. So if you're going to go for surgery tomorrow, what will happen? You have to give anesthesia. If you give anesthesia, they are chemicals. The blood pressure will shoot the roof because you have not controlled the blood pressure prior to taking up the patient for surgery. So you have to do something called an alpha and beta blockade, we say. That is, you give different kinds of antihypertensives, BP medications, both blocking alpha receptor and beta receptor, reduce the blood pressure, prime the body, and then start your main treatment. Main treatment is either surgery if you can remove it. Cannot remove surgery, give some form of radiation. Even if it has spread, surgery is an option, even for the primary and for the metastatic side. If you can remove all the mets, suppose liver you have two lesions, you can remove both, wonderful. Lung you have two lesions, you can remove both, wonderful. Remove the primary source of the tumor also. If you cannot do a surgery in because of the location, this area, jugulotympanic, you cannot remove completely, then give radiation. In metastatic cases, chemotherapy is an option. We give certain TKIs called sunitinib, cabozantinib, etc. Finally, because it's a rare tumor, it is not wrong to send the tumor for NGS, which we keep talking, to look at options, like if there are actionable mutations, to look for those options.
So, sir, would you say that all the patients who come with this disease, they could all have the option of surgery, or like maximum patients would go only for chemotherapy?
No, no, no. Most patients will have an option of surgery. You should do surgery. Why? First, you will know the diagnosis. Two, you will remove as much as tumor possible or the whole tumor. Three, you are removing the source itself. So secretion goes down. So the patient's symptoms go down. Four, if you do a surgery of the primary, if there is metastatic disease also, that tumor responds well to chemo after surgery is done. So surgery is mandatory if you can do in difficult locations, frail patients, inoperable patients, unresectable, you cannot remove the tumor, then you will think of other options. So I will do alpha beta blockade, stabilize the patient, think of surgery, inoperable patients think of radiation. Surgery removes the tumor, gives me a diagnosis, helps me if it has metastatic disease to respond well to chemotherapy. And if it's a secretory tumor, you are removing the source of secretion. So the patient's symptoms will improve and quality of life will be very good. So surgery is the most important part.
Sir, is there any chance for immunotherapy to be used?
Any solid tumor, as we always discuss, if your MSI high, TMB high, tumor mutation burden, microsatellite instability, you can probably benefit from immunotherapy. The number of patients, if I am sure, are extremely low if you look at the original trial also. But technically, yes, for which you have to do NGS.
Okay. So, sir, we have spoken about surgery, we have spoken about chemotherapy and immunotherapy, but the mainstay for this tumors, the treatment for these would be targeted therapy.
Targeted therapy, if you are not able to, chemotherapy, we give doxorubicin, cyclophosphamide, I think vincristine. Another option is, as I spoke to you, is TKIs, tyrosine kinase inhibitors. This tumor has some downstream signaling, certain we call that the RAS, RAF, MAP, MEC pathway, we call that. So you are blocking it at multiple levels with drugs like sunitinib, cabozantinib, etc. So these are tablets which are used in kidney cancer, which are used in thyroid cancer. You also use it in this cancer in stage 4 patients in whom most options are exhausted.
So, how would you say the prognosis for this disease is?
Benign tumors, excellent. Resectable tumors, very good. Sometimes you have small tumors, you need not do anything also. They are very slow growing. Okay. So the prognosis is excellent for benign, small tumors, asymptomatic, slowly growing, completely resectable tumors.
Sir, is there a chance for these tumors to come back, or is there a chance for recurrence?
Like any other cancer, it has.
So, what
That's
would
why
you,
you will do imaging with PET scans or DOTA PET scans after your chemo or your TKI to see if they are having a relapse.
sir, how do you counsel your patients regarding the nutritional requirements and for the lifestyle changes if diagnosed with these tumors?
So the blood pressure is your main concern. Right? The rest of the nutrition may not really help, but blood pressure, right? So you will ask them to have a salt restricted diet and a high protein diet. That is what I would think of. And your proper use of your BP medication so that your blood pressure doesn't go out of control. And that's about it. Don't do heavy gym exercises and all that because you don't want a surge of high blood pressure in yourself.
So, what would you like to give as a message to the general public regarding awareness for this tumor?
It's a very rare tumor, please understand. If somebody is having constant high blood pressure, high heart rate, not responding to conventional medications, and completely worked up, think of this as a possibility. And if this is a possibility, then they need proper imaging. They can be secretory, non-secretory. They can be benign or cancerous. They can spread or not spread. Surgery is the treatment of choice. If not surgery, think of radiation. Finally, chemotherapy and TKIs if it is stage 4. If this message goes through, that is more than enough.
Sir, can you elaborate a little on the second opinion campaign that you run?
So we have a second opinion campaign for the benefit of our patients and their caregivers. If you have a patient who is suffering from cancer, put up those reports on the WhatsApp number you have. We will try to give you an opinion. It is free and it's only to give you a guidance. Uh, and after that, obviously, you are free to take treatment wherever you are. This is just to guide our patients who feel lost when they are diagnosed with cancer.
Thank you for enlightening us on such a rare tumor today. We hope to meet you again next Friday with another interesting topic. Thank you,
Thank you
sir.
so much. Thanks. Okay, Ketty. Ketty, thanks so much to you and your team. Hello?
Yes, sir. Technical glitch. Yes.